All right, let's talk for a moment about the depressive self. Depressives believe that they are bad. And what you find frequently with depressive types is that they will inevitably destroy relationships. They'll push people away. Not consciously, not intentionally, but as the result of unconscious experiences of their own guilt, shame, badness. They don't feel like they deserve good relationships, so they find themselves engaging in behaviors that drive the relationships away. This is the direct result of they themselves feeling rejected by the parents. Depression is one of the clearest developmental defensive styles. If a child experiences neglect, abuse, abandonment, and I don't just mean actual physical abandonment. It isn't just about broken families, divorce, that sort of thing. It isn't just about physical abuse or severe neglect. This is a psychic dynamic, and what may appear to be a perfectly intact, reasonable home can result in depressive dynamics in the child. What the child takes in from the parents is not what the parent says. It's not the lessons they learn cognitively. It's the emotional experience of the relationship. I had a patient recently who was describing a discussion with his 4-year-old son. And the 4-year-old son was being a little difficult, was testing the boundaries, was being disobedient, was not particularly disrespectful. And my client was enraged by that for reasons of his own developmental history. And when he described what he said to the child, it sounded reasonable. When I asked him what he was experiencing in the moment, it changed the entire picture. What the child was taking in was his father's hate of him, rage at him. That's where the depressive dynamic comes from, because the child, I believe I also suggested this, something like this at the beginning of the lecture on depression. If a child is faced with intense emotional experiences of hate, rejection, abandonment, resentment, frustration, anger, anxiety, the child only has one choice. Either it's the child's fault, the child's bad, or the child must accept the reality that the parents are unstable, crazy, and unreliable and untrustworthy. No child can allow that thought to come into their mind, even probably most especially when it's actually true. So the child takes the anger that its experience of neglect or experience of parental anger causes in it and turns that anger back against the self. So the feeling of rejection turns into an experience of self-rejection. The depressive self is created. It is astonishing sometimes the depth to which depressive patients hate themselves as a direct result of this anger turned back against the self. It's a constant source of amazement, the depth to which many of these patients, the depth of self-destruction that these things result in. I think most people accept now that alcoholism is primarily a derivative of depression, and everyone knows the unmitigated destruction that causes. A depressive who drinks, and that's, I believe at this stage of the game, most alcoholics are primarily depressive in their unconscious dynamics. All alcoholics know that drinking is punishment. The reason they can't stop is because unconsciously they feel like they deserve that kind of punishment. Now, what happens sometimes is, as a reaction against that feeling of guilt and need for punishment, some people end up being activists, philanthropists. They try to sort of counterphobically almost, reaction formation. They try to do good. They become compulsive do-gooders to make up for the sense of their own badness, as if they do enough good in the world, they will be relieved of this sense of evil badness within them. It doesn't work. All the goodness in the world will not fix an internal experience of childhood rejection. McWilliams, in her text, points out that women, more than men, are subject to depressive dynamics. She says that women are at greater risk of depressive processes given gender differences. I think this is one of the very few places in the text where I simply disagree with her. I think depressive dynamics are gender neutral. Just as many men as women can be found to be depressive. What happens is in our culture, there are more or less acceptable ways to present depressive dynamics. Women in our culture have a slightly privileged position in relaying their pain to others. Men relaying pain to others is taboo, prohibited, discouraged at the very least, so that women presenting to therapists present statistically in far greater numbers with depressive dynamics. They suffer, they feel bad, and they are willing and able, because they're allowed to as a function of cultural value systems, to be able to relate more honestly. Men do not have as broad a latitude, do not have the cultural permission to describe their pain in that way. So they much more rarely present in classic depressive terms. They present in other terms. They present with alcoholism, drug addictions of various kinds, addictions across the board. So my guess is that if you take all of the addictions and the depressions that men show up with, and all of the addictions and depressions that women show up with in clinical practice, you're going to find just about exactly the same percentage. That's my guess at it. How does a therapist react to the presence of a depressive? And unlike a narcissist, who is annoying to be around, depressives are sort of the classic patient. They're easy to love. They want connection. They are searching somehow, and sometimes rather desperately, for a healing connection to make up for the loss of their childhood developmental experiences. The downside can be that the feelings of guilt can be projected into the therapist, and the therapist can then suffer along with the patient sometimes. A therapist has to have sufficient of his or her own therapy to recognize these dynamics. It can be an experience sitting with a depressive can make the therapist feel incompetent, damaging, blundering, not good enough, hopeless, demoralized. It can be rather infectious, it seems sometimes, but that's just actually the psychological processes of projection. If you deal with a great number of depressives as a clinician, it is absolutely essential that you have a good life yourself, that you have worked through some of your issues, that you've got a place in consultation to take these difficult patients and process your own inner experience of them, or it can be rather depressing. Students, patients, everyone comes up at some point in depression with the question of medication. And I think there's 4 or 5 issues in my field that are intensely controversial and intensely political, and this is one of them. Just a few years ago, the cover of, I believe it was Newsweek magazine, had a story on the largest meta-analysis of antidepressive medications ever conducted, and the shocking conclusion was that antidepressive medications do not work any better than a placebo, a sugar pill. That in fact the only meaningful improvement caused by the pill was through the suggestion by the physician that it would help, not any actual clinical, physiological, brain function change caused by the medication itself. Billions of dollars being spent on antidepressive medications. It appears that there is now good clinical data to suggest that is a catastrophic waste of money and time. And I would suggest even worse than that, because if it does no more than at most suppress a symptom and never actually gets to the core of the problem, which is all any psychotropic medication can do actually, then it gives people the false idea that somehow the pill will cure them. That's a prescription, not just for useless medication, but a prescription for ongoing, continuing, unrelieved suffering. And I think there's bound to be, based on that one study, more. And I don't know if our cultural tendency toward pills can overcome the scientific validity of these studies. People are highly motivated to look for a quick and easy and painless fix until and unless they find the courage to address the meaning of these depressive dynamics. I think we're in for a great deal more suffering. So how, if someone does understand that and wants to seek therapy, how's the therapist supposed to treat them? Well, this is almost the classic psychoanalytic formulation. Basic respect, acceptance, a compassionate effort at understanding the developmental dynamics, an attempt to not be judgmental about the self-destructive tendencies, a grounded maintenance of reality and boundaries. All the things that any good therapeutic experience would entail, I think, are the core of any therapeutic experience with depressive dynamics. Depressives are painfully sensitive to abandonment. That is their core developmental experience. So the error that many therapists make is to try to be too giving, too nurturing, too consistent in their availability. And it turns out that has a problem. It turns out that uninterrupted care, therapists willing to make great sacrifices for the patient, maintains an infantilizing dynamic with the patient. And the best quote I've ever read about this is this: they need to know that their anger at being abandoned did not destroy the relationship, and that their hunger did not permanently alienate the therapist. One cannot learn these lessons without enduring a loss in the first place. So that the therapist must maintain normal boundaries. They get to go on vacation. They get to not work weekends. They get to not work evenings, if that's their style, if that's what they want to do. It is not that the patient is abandoned by the therapist, because inevitably a patient must be abandoned at the end of the given therapeutic hour. The question is, can the therapist and the patient working together come to understand the patient's reaction to that abandonment? Can the anger that has long since been repressed in the patient surrounding their original developmental abandonment, can that be brought into the therapy in the transference when the therapist inevitably abandons the patient, and can that be brought to conscious awareness, understood, and made meaningful? I think that's the profound and truest road to healing with a depressive patient. This is another quote: the pathological reaction to anger is the problem, not the anger. Therapists have to be able to acknowledge and contain a patient's legitimate anger. If they can't do that, if they think that anger is bad, if they think that aggression in and of itself is a problem, they'll never heal a depressive. Anger, frustration, aggression are common human emotions that have to be understood. Depressives have repressed those for a great deal of time. To allow them to be brought out in a controlled environment, to allow them to be understood is the key to therapeutic improvement, not squelching them even further, not having the therapist react with his or her own neurosis when it comes to those concepts. Aggression, anger, frustration, these have to be brought out and understood, not continue to be repressed or displaced. A third problem with depressives is that because they feel so bad about themselves, they tend to idealize the therapist. And that can never be sustained, because the therapist will make mistakes inevitably. And the problem is, idealization has as its counterpart devaluation. If the patient idealizes a therapist, the inevitable failure will result in probable termination and a blowing up of the therapy, because the patient will wrongly view the therapist as either all good or all bad. Neither one of those are true. Neither one of those are sustainable. So the therapist has to be clear of when he or she hears these idealizing transferences, to point out the small mistakes, to humanize, in a way, themselves and the process. The key idea here is that a patient that idealizes the therapist inevitably infantilizes themselves, makes themselves dependent, criticizes, feels themselves to be bad. It's a symptom. To idealize the therapist is a symptom of depression in the patient and should be treated as that. It's difficult for a therapist who gets praised so eloquently to say, no, really, that's a symptom of your depression, and I'm really not that good. It's seductive to hear compliments, and we all can be pulled into that without too much trouble. I'd like to shift now to the manic part of the defense of depressive dynamics. And there is again, one of the controversies in the field is the renaming of what Freud and his co-worker Carl Abraham in the teens and 20s called manic depressive illness, which has been around for 100 years or more. Well, it's been around forever, but it's been called something specific and understood as a specific syndrome for well over 100 years. I believe it was in the Diagnostic and Statistical Manual, 3rd edition, possibly the 4th, where the traditional manic depressive illness was changed. The label was changed. The name was changed to what we now understand as bipolar disorder. The problem with that is that it sounds so balanced, bipolar. There's a north and a south, east and a west. And the implication from the word is that there's balance, that it's equal. It's one and then the other. But there is no one in my field who ever thinks that way about bipolar disorder. Freud was correct in his formulation that the major depressive disorder is the bedrock of manic depressive illness, of bipolar disorder. The manic part is a reaction, a psychic reaction to the depression. They're not equally balanced. The depression is there, it is pervasive, it is almost a personality characteristic, it is powerful, and the manic response is a response to that depression which comes and goes cyclically. Okay, so we haven't done away with Freud by avoiding Freud's language, is the short answer to the problem. What happens to folks who shift into a manic phase of bipolar disorder? You get the experience of elation. They are self-promoting. They are witty. They're overly cheerful, highly social, given to idealization of themselves and others, work addicted, flirtatious, articulate. And those things on the surface don't sound particularly bad. It's just that what happens is they are not attached to reality, and they are driven because it's a symptom of avoiding. It's a technique, a defense against feeling the profound sadness of their depressive elements. Then these, what look like or could be positive emotions, are unconnected to anything in reality and can result in quite destructive behaviors. At the borderline and psychotic level, we have manic responses that give people the impression that the person thinks they're invulnerable, immortal, utterly convinced of success regardless of what's happening. Acts of impulsive exhibitionism, and when it comes to relationships, this is in rare circumstances, you get physical violence, rape even, authoritarian control at the very least in the more severe cases of this. It can look psychopathic. It can look malignantly narcissistic, some of the differential diagnoses. The problem is manic responses are a defense against the depression. So underneath the mania, we have guilt about their aggression. We have their inability to stand being alone. They in these states have almost no empathy. They're not capable of any meaningful human loving connection. Their cognitive styles are unsystematic. They're random. They're chaotic, in fact. Probably in mania, the main defense is flight, denial, acting out, those three things. Anything that gets them away from the feelings. The acting out in all of these sort of high energy ways is exactly that. It's an acting out. It's an attempt through behaviors to not feel. That's the nature of the defense. There are some gender differences here that become very problematic. Men tend to be aggressive when they get this way, and it results in some of the things I listed. McWilliams cites a dentist who, in a manic phase of bipolar disorder, went to his office on a Saturday and took a sledgehammer to a couple of the walls of his office because he was going to be able to add 5 more chairs and he could see 15 patients at a time. And he started tearing walls down. Well, somebody heard about it, got a handle on him, got the hospital people to show up, and he was hospitalized for a while. It was that destructive and that dangerous. So men tend to act out a little aggressively in a manic phase. Women are consistent in their acting out sexually. I have listened to news reports over the last 10 or 15 years of female middle school teachers who are caught having sex with their middle school male students. And I believe, without exception, at some point in the press reports, someone's going to note that the woman has been diagnosed bipolar. I don't think I've seen an exception to that yet. And so what we have is a sexual acting out, a manic response against their own feelings of depression that gets sexualized, and this omnipotent idea that, well, it's okay, the rules don't apply, it's going to be fabulous, there's no downside, I can do this, it's good for him, it's good for me. And then when the manic phase reverts back to depression, the wreckage has to be sorted out, and in these cases, frequently prison sentences have to be served. So there are gender differences in the manifestations of manic responses. In terms of the relational patterns in mania, I think it's obvious at this point that it's the same traumatic separations, abandonments, losses that are uncontained in childhood that result in major depressive disorders. And it appears that if a person is diagnosed bipolar, that those abandonments have been so severe that the patient is driven to a manic response, so that we end up with a developmental assumption of increased trauma that results in the increased severity of the defensive manic reaction to depression. Maybe one of the key elements that developmentalists have identified with bipolar disorder is that the children are neglected, abandoned, abused, or subject to traumatic losses, and almost always never have an opportunity to process the losses emotionally. They get no help in the face of traumatic losses. Things are papered over, things are denied, things are simply ignored for the family's own pathological reasons. The child is then left to stew in these juices, left to stew in the traumatic abandonments, and if it's too severe, can result in a manic defense against the loss later. Part of what the mania is attempting to do, and this is the only way it makes sense, if you see these people doing things, they can almost look psychotic. What they're doing is just crazy. But if you look underneath, if you look at the meaning of the behavior, what you find consistently is that they're running to avoid fragmentation, that the acting out has a psychic purpose. If they don't keep doing things, they fall apart. And I think everybody can identify with that to some degree. If you're agitated, if you're anxious, you want to walk around, you want to do something. You can't just sit still. You want to move. And I think in a manic response, that dynamic, that response is 10, 20-fold or more. And so we may be able, if we can think in those terms, to perhaps at least identify a little bit with the person in a manic phase. I think folks in a manic phase of bipolar disorder are oftentimes at risk of suicide, and we have to be very mindful of that as clinicians if they're in a position where their mania is simply contradicted, if they are unable to substitute their manic defenses, if they are stopped without emotional containment of some kind, they can then be basically precipitated back into the middle of a major depressive disorder, which is intolerable to the point of suicide for some people. So handling a manic person, handling a depressive in a manic phase, is serious at that level, has to be taken very seriously. And I think people should know that if you know someone with bipolar disorder, and it's not an uncommon disorder these days, one has to be very careful. Okay. Therapists handling manic depressive, the biggest problem is not when they're in their depressive disorders, because people with depression, as I said, generally tend to be willing patients. It is when they get into the manic phase that they feel like they no longer need therapy, that everything's fine, they're good. And so the main effort for a therapist with a manic patient is just trying to keep them in therapy, trying to keep them from blowing it up, trying to stay a little bit in reality. And I think with that, we can move on to chapter 12, masochistic or self-defeating personalities. Now, Freud was aware of this. In fact, it was these kinds of patients that evoked in him sort of confusion. He initially had the reality principle and the pleasure principle. He thought those two things explained most people's behaviors. But then he saw a class of patients who kept hurting themselves, kept hurting other people. He saw people doing things over and over again. He called it the repetition compulsion, but it didn't make sense. It didn't make sense in terms of his key theories. People do things for pleasure, and they avoid doing things that are painful. Common sense. He also thought people did things that adjusted them to reality in a better, more effective way. Makes perfect sense there too. But then there's this class of patients who seemed to defy those two principles, defied reality and defied pleasure, and ended up repetitively, almost rigidly, in a driven way, doing things over and over that were endlessly painful. He called it moral masochism. And his insight, I think, remains valid today. People don't like pain. All right? There's a bit of a misnomer that somehow if you're called a masochist, that means you like pain. Well, nobody likes pain. Pain hurts. And so that's just wrong. And I think it gets tied more often than not in our culture to sexual acting out, the sexual masochist, the one who seems to get an erotic sense of satisfaction out of being humiliated, controlled, dominated. Well, there is no pleasure in pain. What Freud recognized is that there's some higher goal involved. There's some unconscious motivation involved. And I think at the core of it, a masochistic personality, masochistic tendencies represent a kind of martyrdom, that they get something out of their suffering. Again, it's not that they like the pain. They're getting something through the experience of suffering that makes the pain worthwhile. And in fact, it's potentially more problematic than that. Not only do they get something out of their suffering, they get something so powerful they don't want to give it up. And they will endure seemingly endless suffering, seemingly life-destroying levels of suffering in order to maintain that moral righteousness of the martyr. And here's again where we have these interesting cultural dynamics that reinforce a pathology. In Western civilization, we have the three great monotheistic religions. We've got Christianity, Islam, and Judaism. And as far as I can tell, there's only one thing all three of them agree on. One thing and one thing only. And that's martyrs to the cause are at the right hand of God the same day. You die a martyr for one of the three great religions, Western religions, and you will go straight to heaven that very day. We have a tradition in our culture of valuing, giving one up for the team, taking the hit for the team. The martyr is morally privileged. The problem is when that tendency gets used by a mind to provide a defense against anxiety, it can become quite pathological. And because it has social reinforcement, it can become very hard to change. The classic example is the victim of spouse abuse who stays for the children, who stays because she's such a good person and such a caring mother, who loves her husband and doesn't want to end the marriage. There may be people like that, But if you look at those situations closely, 99 times out of 100, what we have is a case of masochism. And just to be gender neutral here, it appears that just in the last few years, the number of domestic violence victims that were women are now exactly the same as the number of domestic violence victims that are men. Women are now equally likely, according to federal statistics, to be the perpetrators of domestic violence. Welcome to equality, ladies. How does it feel? Is the joke here. A sad joke, I'm afraid. So I will use this example because I think it's in our culture now so common. A domestic violence victim is in fact responsible for her abuse. Oh my God, what have I just said? I'm blaming the victim here. That's politically incorrect. That's cruel, that's harsh, that's judgmental, that's unfair. No, it isn't actually. She's not responsible for her emotional dynamic. That was laid down in her childhood when he or she had no choice in the matter whatsoever, and that is not his or her fault in any meaningful moral terms at all, ever. But what is their responsibility now, what is the masochist's responsibility now, is to find the courage to recognize the underlying meaning of what they're doing. Because the simple truth is, there is no domestic violence situation that's good for the children. To allow the children to be present during a domestic violence is trauma, is abuse, is at the very least severe and severe neglect of the worst sort. And so the rationalization, which is what it is, which is one of the key defenses in masochism, rationalization, is a way for the masochist to continue to get the feeling of their moral superiority in their suffering. They point to the abuser as the bad one. They point to themselves as the righteous sufferer who's doing good for the children, who's committed to the marriage. And I hope I don't sound sarcastic, but I've heard this so many times that my tendency is to sort of be saddened, almost roll my eyes, because it's now so common, it can be seen almost as a caricature. It's so obviously not true given what we know now about child development. There is no sane argument that anyone can make for allowing children to witness domestic violence. There is no good that comes out of that under any circumstances. And here's the complicating factor. I think one of the things that underneath the righteousness of the martyr in masochistic dynamics, one of the things that makes it particularly difficult to change is that and this is one of the things that is the hardest for a masochist to accept, is that they are themselves hostile, that there is an element of revenge in their suffering, that there is inevitably an aggressive attempt by the masochist to show how they are superior and put the other one down. It is almost inevitably in a masochistic dynamic, you see in the masochist the righteous searching for revenge. It's all couched in moral terms and suffering and I'm trying so hard. But you see the way they eagerly tell their story to the responding police officer in the 911 domestic violence call, to the victim advocate at the shelter, then the next one and the next one. And what happens the next week when it all happens again and again and again? They get to tell their story over and over. And the compulsion almost to do that has an element of hostility in it, has an element of revenge and aggression in it that is almost impossible for the masochist to acknowledge, because they're the victim, they're the suffering one. To acknowledge that in fact part of their suffering has an aggressively hostile element to it is psychically almost impossible, and one has to proceed in this way very, very slowly. Now I want to differentiate with some sophistication the difference between the sort of martyrdom dynamic in traditional masochism and what we see today, a fair amount of the self-mutilation, the cutters, branding, some tattoo artists, tattooists. There's something entirely different going on in the self-mutilation, in the cutting. That has an anxiety management component to it, often at the quite primitive borderline level. And I want to separate out. I don't think those two categories should ever be put together. I think they're very different in terms of their psychological dynamics. What I'm talking about is the classic formulation of moral masochism. A consistent danger for the therapist is to misunderstand depression and masochism. This happened to me several years ago. I had a patient who was clearly depressive, and he was. And we worked together for a couple of years, and somehow the work seemed to be getting stuck. I couldn't put my finger on it. The interpretations weren't being effective. There wasn't much movement. He was frustrated, I was frustrated, and then I actually reread the portion of this masochistic chapter in McWilliams' text in preparation for a class, and I went, oh my God, that's what's going on. My diagnosis was not entirely adequate. He was depressed, but there was a streak of masochism in him, and it wasn't until I could interpret that martyrdom tendency, that tendency toward a little bit of revenge, that tendency toward a little bit of superiority in his suffering, that I was able with him to break through that, and the work continued. It was close to ending the therapy because we were both so frustrated. Had I not recognized the masochistic dynamic, I'm certain at this point that it would have been a failed therapy. Like the depressives, if we're going to talk about the defensive and adaptive processes in masochism, turning against the self, idealization, introjection. Masochists heavily rely on acting out in ways that risk harm. And there's also, I will add another element to this that makes it especially complicated. When a masochist puts him or herself in the position to be harmed, what frequently therapists notice is they're recreating something that seems almost exactly like their developmental disasters as children. And you see them recreating the sort of, the painful dependency situations where they're hurt, abandoned. And it turns out that there's a way of the way their behavior operates as an attempt to master the trauma. This is an attempt to be in charge of the trauma. They elicit violence against themselves in a way that they control, and therefore they're not just passive victims, which is intolerable psychically. They're actually evoking it. They're in charge of it. They can create it and are therefore, at least in some fantasy feeling state, they're potent, capable, in control of it. And I think what we find with that is one of the things that makes it hard, again, to treat, is that they falsely and pathologically experience their masochism as control and power in a way. That the masochist knows that the sadistic person who's hurting them desperately needs them for their own completeness. That, in a disturbed way, gives the masochist a great deal of power. At the end of the day, one of the elements is that the masochist attempts, through the recreation of their suffering, to master the initial trauma psychically. Theodore Reich came out with an understanding of sort of the dimensions of masochism, the sort of process, and there's a provocation. A masochist knows how to push the buttons of the sadistic partner. Then there's appeasement. They fawn, they bow, they submit in some ways. Then after the abuse, there's this exhibitionistic, see me, the martyr, the suffering one. And simultaneously, there's this deflection of guilt. See, I am the innocent victim. And putting that's the revenge element, that's the control element, that's the aggressive element to the masochism. Provocation, appeasement, exhibitionism, and the deflection of guilt. And I would add into that aggressive revenge element. In terms of childhood development, it seems that the masochist is like the depressive, but they haven't been quite as abused. They're more relationally focused, more object relationally available. McWilliams describes it as a depressive who still has hope. The problem is, the hope is if they suffer enough, they'll be loved. The depressive doesn't believe they're good enough to be loved. They think they're bad. They think they're rejected. They're so bad they can't be loved. The masochist dynamic is that if they just suffer enough, they'll be loved. And you get how this might happen in children. How many children have you heard about where they act out and they get punished? But that punishment tends to be interpreted by them as better than being abandoned. When a parent neglects a child, when a parent ignores the child, what happens is somehow the child figures out that if they're bad, they get punished. And that feels better than abandonment, because I think there's something biological, primary, genetic, evolutionary, that says to a child, and I think frankly to adults most of the time, that the worst possible danger to us as an individual is to be thrown out of the tribe, is to be abandoned, is to be banished. So a child who in their developmental, in their family dynamics, associates pain, associates relational trauma with at least some kind of connection as opposed to abandonment, will recreate trauma over and over again because it's the only connection they know. Being beaten is better than being neglected, is the masochist's horrible dilemma. If you tie pain and love together, if you tie love and suffering together too closely, then you end up with a masochistic dynamic and people recreating pain because the meaning of it is at least some kind of connection in the face of anticipated or fantasized abandonment. And it's fantasized now because it was real in their childhoods. I guess most people call these things secondary gain. Masochists get secondary gain from their attachment or connection through suffering solutions. And the result I have seen over and over in my own clinical practice is that when I get someone who's got a masochistic tendency and I say something about maybe taking care of yourself in a different way might be more effective, or when I make a suggestion, I'm often just rejected out of hand because that would be selfish. They don't want to be selfish. You don't want me to be selfish, do you? And that's the moral cover under which masochism seems to be almost impossible to root out. That we, again, it's a cultural dynamic. Selfishness is a bad thing, so we don't want to be selfish. And a masochist will often rationalize their suffering because the alternative is being condemned as being selfish. Oh, I certainly can't do anything for myself. Oh no, that's not acceptable. I have to sacrifice for the children. Recipe for a disaster for the children most of the time. How does the therapist respond to a masochist? It depends on the therapist's own personality. One of the things that masochists do with therapists is they will evoke a sadistic response in the therapist. If the patient acts that way, a therapist has to be very careful not to play into the pull to be sadistic. If therapists aren't themselves well analyzed, haven't had enough of their own therapy, you can be hooked into a punishing dynamic with a masochistic patient very easily. A good therapist with a masochistic patient would not make any sacrifices, would not model masochism to the patient. Very few, if any, expressions of sympathy are appropriate to a masochist. Staying in reality. You don't rescue them, you don't make them feel good about what they're doing and experiencing. You can model your own self-care without guilt. You stay in reality. You don't give them rewards for suffering in the therapy. And I think most particularly you gently and respectfully and with some understanding name the irrational beliefs that the masochist clings to so desperately. The more you do that, the more likely it is, slowly and carefully, and sometimes painfully slowly, the masochist might come around. Okay, let's shift to chapter 13, obsessive and compulsive personalities. And if you haven't seen the movie As Good as It Gets, I strongly recommend it. Jack Nicholson plays an obsessive-compulsive character as brilliantly as obsessive-compulsive has ever been portrayed on the screen. He's absolutely brilliant at it. He could be a footnote in the Diagnostic and Statistical Manual of this character. Helen Hunt plays his love interest in this, and he goes through every classic symptom of OCD. And in the end, you end up feeling some empathy for him. And one of the cultural dynamics that we have, that when it becomes pathological can be seen as problematic, but the cultural tendencies seem to be valuable in and of themselves, at least on an intellectual level. OCD are personalities organized around thinking. If you're obsessive, you're having obsessive thoughts. If you're compulsive, your mind is organized around doing, compulsive actions. But thinking is privileged in Western civilization. We've got the Enlightenment project. We've got thoughtful people. We've got philosophy, the tradition of philosophy, where thinkers are supposed to spend time thinking. That's a good thing. We've got statues called The Thinker. It's a beautiful thing by Rodin. We privilege thinking. I think especially in technology, in science, thinking is privileged. And it's a thin line sometimes between thinking as a cultural value that results in great good and the line between obsessive thinking that becomes a category of mental illness. Similar, in our West, we like action figures. We like doing things. We're proud of our ability to get the job done. When does doing things translate into pathological symptoms? And the key here is the nature of the unconscious motivation. It's not the thing, it's the meaning of the thing. And the difference between, for example, an organized professional. You can look very organized and be very professional. What's the difference between an organized professional and someone who's obsessive compulsive? They can actually look a lot alike. The answer is underneath. It's the drivenness of the behaviors. It's the drivenness of the thinking process. It's the defensive nature. If I am an organized, committed professional, I do things because I want to be successful in life. And that kind of approach is often very useful. In fact, results in a lot of success. The obsessive compulsive engages in obsessive thought processes and compulsive behaviors, not to be successful, but to avoid anxiety. It is, like all of these in the horizontal axis of McWilliams' little chart, it is a defense against anxiety. It is, in this case, one of our cultural commonalities that gets translated, mutated into behavioral ineffectiveness, into pathology, into symptoms that can't work very well in reality, given what they're actually trying to do. And like most of our categories of mental illness today, Freud had something very similar back in his day. He thought obsessive-compulsive behaviors were developmentally evoked around some conflict in the child's development around 2 years old, around the potty training time. And he noted a connection between the ramifications, the derivatives of potty training, the anal issues he called them, that didn't work out very well, that people became sort of focused on dirtiness, cleanliness, time, money. These things had symbolic relationships to the first conflict with parents. And that's what Freud noticed is represented by potty training. It's the first time the child and the mother, for the most part, are at odds with each other, and how that initial conflict, a conflict, of course, which the child must lose inevitably. Children don't know any better. They enjoy defecating in their diapers. It's a source of some pleasure to them. And to be told, no, you can't do that, you must do it over there, and sometimes you must do it when it's convenient for the parents, this is really the first major conflict with the parents. And the child's mind, if it's contained and if there's adequate love, can work through that first conflict without significant pathology if there's a problem at that time. Then it becomes, frequently, the derivatives of those problems get focused on questions of control, get focused on questions of aggression and its management. If the child is angry, if the child feels aggression in the context of that potty training experience, and the dynamics get translated into OCD behaviors and thought processes, what we have is the context of an attempt at rigid control. That's what OCD is about more than anything else. The mind of the OCD sufferer is about containing, maintaining a rigid type of control against these anxieties, against these feelings of anger and aggression that if they don't control tightly will blow up. That's the anxiety that is being defended against in OCD. And it has its source in that early developmental experience. They feel rage at being controlled. They feel fear at being condemned and judged for not obeying simultaneously. What ends up happening is that their emotions become repressed, muted, suppressed, unavailable. You see them as rationalizing. And one of the key characteristics of an OCD personality is the fact that their words are not used to express emotions. Their words are used to conceal emotions, to conceal feelings. They intellectualize about their feelings. They can talk about their feelings, but they never actually feel them very much, with the exception of anger and shame. An OCD person can be angry and can feel shame and react to it rather intensely. One of the key defensive maneuvers of the OCD person is this isolation of affect. You see them compartmentalizing their emotions and thinking about them. There isn't a whole there. You don't have a sense of a whole person when someone is in the midst of OCD dynamics. They will, if it's primarily cognitive, they will privilege thought and devalue feelings. They can they can withdraw. I think in the movie As Good as It Gets, you see the character, he's a writer, so he lives alone. He's in isolation. He hardly has any human contact at all. And when he does, it's really quite rigid and formalized. That looks a lot like schizoid dynamics. So this is one of the defensive styles that's easily misunderstood as something else unless you look closely. If you are compulsive, and by that, and we see a variety of behaviors that can be described as compulsive. The classic ones is the guy who washes his hands 17 times a day. The person who has to go back and check the lock 10 times on their door. The one who checks whether the stove is off 10 or 15 times to the point where they don't make it to work on time frequently. A little bit like the martyr in masochism, rituals, behavioral rituals, which psychically are really all about undoing. Sort of, it's almost a magical thing. If I do this, then the bad thing won't happen. That old childhood rhyme, that children, I've heard children do this. I remembered when I was a child hearing this or experiencing it somehow. Children walking on a sidewalk, and they'll skip over the crack. Step on a crack, break your mother's back. And so they avoid it. It's a little nursery rhyme. It sounds so strange, but it's innocent sounding. Well, no, they're stepping over the cracks because children have aggressive thoughts and fantasies toward their parents, specifically their mothers. What they're trying to do is undo their aggressive fantasies toward their mothers by not stepping on the cracks. It sounds strange, but it makes perfect sense. How else do you explain the rhyme? Children's aggression toward the parents, the fantasy of breaking her back, is undone magically by this behavior, compulsive behavior of not stepping on a crack. It only makes sense if you understand that the child's mind at the time of these thoughts is not developed in a way that can cleanly separate fantasy from reality. The key to understanding this, as bizarre as it seems to sound sometimes, is recognizing that children, when they have thoughts, very young children, cannot tell that what they're fantasizing is not happening in reality. That their mind is at a time before actions and thoughts are cleanly differentiated. So if they have a violent thought toward their parent, they feel guilty because they have just hurt their parent somehow. They can't tell the difference between reality and fantasy. So the compulsive behaviors are designed to undo the fantasized damage, aggression, hostility. And as an adult obsessive person, these rituals, the hand washing, the checking, the organizing, is designed to do exactly the same thing, to stop the anxiety at thoughts and feelings involving aggression, hostility, fear of being controlled, rage at being controlled. And so under the surface of what seems like a calm, intellectual individual is someone who is torn by intensely dangerous emotions. And a variation on that theme. What we have sometimes with obsessives and compulsive behaviors is the idea that their control is really about self-control. It's about ensuring that they themselves don't do the kind of damage that they used to fantasize about. They are at some level afraid that they have the ability to do great damage. And so their actions are designed to strip their minds of any possibility of that by the constant control that obsessive thinking, the rumination, the repetitive thought patterns, the circular patterns have. If they're doing that, then they're not thinking about death and destruction. Same thing with the behaviors. As long as they're focused on this doing, they're not thinking and they're not doing things that perhaps will be a great deal more destructive. Underneath the OCD person is often a cauldron of rage and aggression. How does this happen? How does this happen in the child? Well, again, in our culture, we praise high standards. We praise excellence. We think high standards and performing at very high levels is a very good thing. The OCD, the person who becomes OCD has had a childhood where that was taken one step beyond healthy development and into pathology. There's a line between high standards and unreasonable premature demands that the child isn't capable of meeting. In families like this, there are always intense issues around control. There is over-involvement with the parents. They are overprotective. They control every aspect of the child's life. They are not allowing the child to learn from their own experience. They substitute moral obedience for the child's exploration of self. They demand self-control. They demand the deferral of gratification. And we end up with children who generate so much rage and frustration and anger that the only internalized experience they have is one of control. And that person can grow up easily to be dominated by obsessive thinking and compulsive behaviors. One of the striking characteristics of the OCD person is that not just control, though that's constantly a factor, there's also a sense of their moral rectitude. This has something vaguely parallel to the masochist. They are righteous in their behavior. And this is the parallel to masochism that makes it hard to treat, because they think they're so good. They have discipline. They're in control. They're doing the right thing. They're actually avoiding, in fantasy, the thing they think is very, very wrong. But you've got to be a therapist with someone in an OCD dynamic. You've got to be able to help them recognize that, in fact, they're not in control. this is one of the ironies of OCD, is that they, in pretending, in fantasizing about all of this control, they're actually not in any control at all of their actual lived lives. That's the example. If you're constantly checking to make sure the door is locked, you don't make it to work on time, you get fired. You're not in control of your career progression. You're not in control of your relationships. You don't have much of a relationship. OCD people are notoriously withdrawn and limited in their ability to be in human connection. How does an OCD person come into therapy? They're hard to get into therapy unless the diagnosis is fairly mild. And I think similar to the masochist, the therapist must simply be a strong example of consistent regard, that not being judgmental, but staying in reality as much as possible, recognizing feeling states as good. I think the best way to treat an OCD person is to be playful with emotions. That emotions can be shown in the therapeutic experience to be not dangerous at all, and in fact kind of fun. And you can comment to an OCD sufferer that his feelings of anger and rage might actually be kind of fun to touch on now and then, to feel a little bit. How bad can that be? It's a shocking revelation to a person suffering with OCD that perhaps feelings might be fun. You have to be gentle and careful about this as a therapist. But the move that probably makes the most consistent progress, the stance of the therapist, is a simple and quiet dedication to emotional honesty. The ability to feel, the ability to recognize that having emotions does not result in spree killings and mayhem. That emotions a little bit at a time cannot just be tolerated, but are actually good for you. That's what a good therapist, I think, models to a patient with OCD. All right, let's move to chapter 14, hysterical or histrionic personalities. Now, this is where psychoanalysis started. This is where the entire century of psychology got started. Freud first worked with what he described as hysterical patients. I think we must recognize that virtually all subsequent developments in psychopathology and psychotherapy have their genesis in Freud's revelations about his work with hysterical, mostly female patients. And I think that the foundational questions in my field that were laid down 100 years ago, I think remain profoundly important. How can someone know and not know something at the same time? What accounts for forgetting important experiences? Does the body express what the mind cannot? These are the things that Freud first struggled with, and I think every good therapist today struggles with the same questions at one level or another. The hysterical type. Hysteria is cleanly and clearly defined as a person with high anxiety, high intensity, high reactivity. They're warm, energetic, attracted to situations of personal drama and risk, addicted to excitement. They go from one crisis to another. Exaggerated, superficial, artificial emotions, rapidly shifting feelings. Well, we're talking about drama queens here. We're talking about the kind of folks I think everybody knows at some level or another. You know someone like this. I think they're common in particular types of professions. Acting, dancing, preaching, politics, teaching even sometimes. You get people whose professional qualifications, whose standards of what they have to do in their professions can be facilitated by hysterical dynamics. This is one of the professional dynamics or the professional requirements can actually match some of the hysterical dynamics here. It would almost be funny if it wasn't so sad in some cases. This does not seem to be a type of defensive structure or style that has very much to do with biology. This seems to be learned. This is entirely a function These emotional dynamics around hysteria are virtually all learned, it seems. This is a direct derivative of childhood relational dynamics. Repression, sexualization, and regression. Acting out what's called counterphobically, meaning if someone has repressed sexuality, they often react in the opposite way. They want to master their fear in some way, but it's not honest. They do things to avoid, in a defensive way, the feelings of judgment and anxiety evoked by a childhood experience. Hysterics will dissociate. That means this is about forgetting. They forget what happened sometimes. They can lose a memory. And this is confusing. It almost looks manipulative. It looks like it can't be true. It looks like they're lying. And this is one of the hardest parts about treating hysterics. And I think this is the core of a controversy that began 20 years ago called repressed memory. The question, and people who didn't understand the history of psychoanalytic theory thought repressed memory was this new and exciting thing. Freud was addressing exactly this dynamic in 1905. The question of repressed memory, there's probably the most famous book was written by Professor Elizabeth Loftus called The Myth of Repressed Memory, where she both acknowledged the hysterical and historical dynamic of a mind that represses things, that forgets, but it's not a memory question, it's repression. That's, I think, an important distinction. If you forget something, it's still in your mind, and with a little prompting and a little luck, you can call it back to memory. That's forgetting. What most people, clinicians, are talking about in hysteria is the repression of a thought, so that it is repressed into, sent into the unconscious, where it is not easily accessible by the conscious mind. That is a completely different psychic dynamic than forgetting. Repression is what the hysteric does, and therefore they do not truly have access to the memory. Therefore, when you talk to them, it didn't happen. And they are absolutely convincing sometimes, because they truly believe that their memory is correct. And if it is not, and here is the great difficulty that was evoked in the 80s, I think, around repressed memory. Are memories accurate? And it turns out, Freud understood with his seduction theory, that memories are not accurate sometimes, that memory is frequently a complex mix of the actual reality that happened and a fantasy, internal, unconscious. Our minds are not a video recording system that can be played back accurately. That our memories are in fact an organic mixture of overt, motivated fantasy and what happened in reality. So we are on shaky ground, accepting as true anything anybody says. I think in the legal field, in criminal defense and prosecution, one of the standard jokes is the least reliable witness is an eyewitness, because they don't know what they see and can't remember it very accurately most of the time, and often will change their stories frequently. I think that is one of the core issues in my field right now that causes so many people so many problems. In child sex abuse cases, in sexual assault cases, in date rape cases, we are on shaky ground accepting a victim statement at face value. Did it happen? Maybe, maybe not. Did it happen exactly the way he or she said? Maybe, maybe not. But it isn't blaming the victim, and it isn't denying the truth of the victim's experience to recognize the truth of the human mind's functioning, that these questions are dramatically more complicated and more problematic than we have given them credit for. One cannot allow the politics of victimology and the desire that I think in a lot of people is in good faith to try to help poor victims. You cannot unquestionably believe everything you're told by a victim, because quite simply a great deal of it may or may not be true. And I think a statement by, I think it was Judith Matrani, a great psychoanalyst from the Midwest, she said once that what happened matters, and what really happened really matters. And the implication is that we're not entirely clear what really happened sometimes. So I get the idea that a person's narrative, the narrative truth of their experience, has to be understood and respected. But competent clinicians who can't tell the difference between a narrative and reality are unlikely to do their patients very much good at all. And I think it was Freud's fundamental respect for his female patient's sexuality. I think it was his fundamental respect for his female patient's sense of self that caused him to recognize a deeper level of meaning in their stories, allowed him to help them. It is not disrespect to be careful about the truth and to be patient with its evolving revelation. To accept at face value the first version of the story you get from someone, I don't believe is respectful at all, because the truth is very frequently it isn't true. I had a patient who I worked with twice a week for an entire year who had gotten in some trouble for the possession of child pornography. And he categorically denied it. He had looked at some pornography, all adult, all legal, all within parameters of legal, and his computer hard drive got sent to be repaired, and it turns out there was some child pornography on it. And he maintained it was a total innocent situation, that some of that stuff had gone on with a larger download, and he'd never seen it. And we worked for an entire year, and he was morally outraged at the prosecutor's abuse, the prosecutor's incompetence and motivated, politically motivated abuse of him personally. And after a year of twice-a-week therapy, he had a memory. And he recognized that he had, in fact, repressed the knowledge that that child pornography was, in fact, on one of his larger downloads of adult pornography. He denied looking at it, but he did remember having it. But it took a year of very challenging work to get to the truth of his experience. And I never agreed or disagreed with him during that year. I tried to struggle with his emotional experience. And had I colluded with his delusion of the truth of his initial narrative, it is clear to me we would have never gotten to the actual truth of what really happened, and that would have done him no good at all. So in hysterical dynamics, this sort of embedded, almost political question of what is true for a patient and what stance the therapist should take vis-a-vis a patient's evolving story is, I think, inevitably embedded. What a hysteric is trying to do is manage an unsafe world. The developmental dynamics in a hysteric are fairly well recognized now. The pattern of parental dynamic in the hysterical female child, in the female child who becomes a hysterical adult, is commonly recognized. And there are gender differences in this. I don't think in the last 15 or 20 years I have heard of any cases where, well, there's two categories: females diagnosed hysterical and gay men. They are what makes up the category of hysterical diagnosis. I have not heard in decades a case of a heterosexual male being diagnosed with hysteria. This does seem to be one of the clearest gender-based or sexual orientation-based clinical categories ever. In the female child's development, you have a mother who is ineffective, who is inadequate, weak, submissive. And you have a father who is sexually enticing, who is eroticized a little bit, very powerful, but dismisses the daughter as weak and ineffectual, and yet having some sort of strange power over men through her body, often very, very vague. The daughter is left feeling powerless and vulnerable, except in this one sort of pseudo-sexualization. I have tremendous concern for these little girls in these baby beauty pageants. I've seen pictures of them on television, and all I can see is the generation of an entire generation of hysterical young women being sexualized at age 5 with their hair done up and their their erotic seeming movements in their dance numbers in these so-called beauty pageants. It seems quite problematic to me. They have been taught that sexuality is both the source of their power and the source of overwhelming danger. The great danger in a hysteric is that they appear to be sexualized when what they're doing is sort of counterphobically reacting against the terror of any sexualized activity. So that a hysterical woman will overdress, will dress provocatively, but she doesn't get, and this is the absolute key to it, is that she doesn't get the erotic component of what she's doing. Men will see the dress and assume that she's conscious of the erotic power she's projecting. And the truth is, if she's a true hysteric, she is not. She's simply playing this role in a defensive way that's trying to exercise power, whatever little bit of power she has, in this strange thing she does that men respond to. But it's absolutely drained of conscious erotic potential. It isn't, she may look like she is intensely sexual, but nothing in her inner experience is in any way consciously sexualized or erotic. It's sad. It's unfortunate. It gets everyone in trouble if it isn't recognized early. And my advice to men, and I think this is good advice, is if you're dating and you end up in bed with a woman on the first night, you are setting yourself up for hell, because the next morning you may be accused of date rape. She had no intention of having sex. You overwhelmed her, she dissociated, and she wakes up in the morning and screams rape, and you go, what? And I think there are plenty of cases where women are taken advantage of and are raped, and rapists, as far as I'm concerned, should have terrible things done to their anatomies and then thrown in the ocean. That's just my humble opinion. But there are also cases where there is gross misunderstandings, and if a woman is diagnostically hysteric, this is where the great danger lies, in the misunderstanding of what appear to be erotic behaviors and men misinterpreting them, and then later the realization happens after the dissociation lifts that something happened that she didn't want to have happened, and therefore it must have been rape. And the problem with the hysteric is they believe what they're saying, and so they are compelling witnesses. When someone is overtly manipulating and lying and making a story up they know isn't true, it is not that hard for an astute police detective to pick up on the subtle nuances and cues of a lying witness. A hysterical witness is often amazingly morally convinced of the absolute certainty of what she's saying. To her, it is absolutely unequivocally true. And this can have devastating consequences. So guys, simple response here. A response that's going to fix any of these problems from ever happening. Get to know a woman for several months before you propose anything like sexual contact. And I'm not taking a moral position on this. I'm taking a psychological one, and one for your own safety. Get to know her first, guys. It's the safer way to go. Therapeutically, a hysteric will come in and will do the same, will appear in the same sort of potentially seductive way to the therapist. And Freud was on this right away. He saw the seduction as a recreation of childhood trauma. And he would not ever be seduced by it. Unfortunately, several of his co-workers and students did not understand in the early stages of psychoanalytic development what was going on. And so several of Freud's first-generation psychoanalysts were having sexual contact with their patients sometimes, and most of the time it was because of the sexually seductively appearing hysteric. The hysterical seduction cannot be allowed to be actualized. The vast majority of therapists in America today who get thrown out of the profession, have their licenses revoked, is because of sexual contact with a patient. 95% of them are men, and I'm going to suggest the overwhelming majority of female patients who end up with sexual contact are diagnostically in the hysterical category. Therapists who have had not enough of their own therapy are likely candidates for this kind of acting out on their part. The patient will be somewhat provocative. That's the nature of the defense. That's the nature of their character. The therapist must recognize, as Freud said 100 years ago, if the patient falls in love with the therapist must remember that it's not because of the therapist's qualities. It's part of the symptomatic picture. Therapists shouldn't feel good about themselves. They should just understand the dynamic in front of them when a patient makes a provocative move. Patients sometimes will fall in love with their therapists, at least on the surface. And so this has to be resisted. What McWilliams says, and I think brilliantly, there is a healing power in being taken seriously, not sexually. The need to acknowledge having and giving voice to powerful desires that are not exploited is the key to therapy with a hysteric. They get to have their sexual feelings, and they get not to be abused. The best quote ever. Trying and failing to seduce someone is profoundly transformative to histrionic people because often for the first time in their lives, they learn that someone they depend on will put their welfare above the opportunity to use them. The direct exertion of their autonomy is more effective than defensive, sexualized distortions of it. I have never read a couple of sentences more profoundly useful to a therapist than that in how to deal with a hysterical patient. If the therapist can maintain their therapeutic neutrality and their perspective, dealing with hysterical patients is very productive. Therapists generally appreciate the innocence of the hysteric. I get a feeling when I'm working with a hysterical patient that I have this lovely little kitten in my hand, this vulnerable little kitten, and I just have to take very good care of it. I can't use it and abuse it. I've got to take good care of it. And I think that quote I just mentioned sort of typifies that fantasy of having something very gentle and very vulnerable in your hands, and the grave responsibility to care for it appropriately, to me, is the best stance a therapist can take. Finally, chapter 15, dissociative personalities. And in the first edition of her text, McWilliams tacked this on because she didn't know where else to put it. She tacked it on to the end of the defensive scale. And it confused her 20 years ago, and I think it confuses her today, and it confuses us, because this one doesn't fit very well. She put the defenses on a scale of object relatedness: the psychopath, the least object related, and the hysteric, the most object related, with everyone in between sort of laid out in accordance with how potentially they're connected interpsychically. Dissociatives, because of their trauma history, don't fit very well. They are intensely able to relate to the therapist. They do seem to have relationships, but the defense of dissociation interrupts the functioning of those relationships and makes a therapy kind of complicated. Again, one of the social controversies in dissociation is that for a long time the diagnostic manual described multiple personality disorders, and that is no longer an acceptable pathological category. It's now dissociative identity disorder. It used to mean multiple personalities. For a long time, I think starting in the 60s and 70s, there was this wave of multiple personality disorders. There were movies about it. Seven Faces of Eve or something like that. And it appears that was almost a political movement that has long since died out. Very few people today in my field believe in that florid, completely separate, individualized personalities inside one mind. There's I don't think any valid theory that can account for multiple individual, different, separate personalities coexisting through one developmental experience. What there is different aspects of the self. Going all the way back to Freud, no one now disagrees that we are complicated creatures in some conflict internally. We have different objects, loving and hating. We have, in the classical formulation, an id, an ego, and a superego. There's different ways of characterizing it, and they all recognize that we are not a consistent whole. So I think what that multiple personality disorder movement did was just take that to a grossly illogical extreme. Where we are now seems to be that though it may seem like a different personality sometimes, that people seem to switch into different altered personalities, most of the time we see now it is different aspects of the same personality. Freud said in 1923, different identifications seize hold of consciousness in turn. I think that's as far as we can fairly go in terms of the clinical evidence. The most complicating factor with dissociative identity disorder and dissociative defenses is that there isn't any dispute that the core of them is absolutely catastrophic childhood trauma. Various studies have been done. 95% of those with substantial dissociative dynamics have been brutally, often sexually abused as very young children. I think that's now universally understood. If you're dissociating, you're traumatized at the worst levels imaginable. This year I've worked with 2 dissociating patients, and their trauma histories, I can't even describe them. They're some of the worst imaginable. And there are stories in literature, and in the media, about a torture victim or a rape victim who survives the ordeal and tells his or her story later. And they often describe this experience of floating above the scene of their suffering, that they seem detached, they seem to be observing it from a distance. That is the dissociative defense. The defense against such horror, such pain, such absolute impotent suffering, such terror, is to dissociate your mind from your body, to separate, and you don't feel the pain then. I think that's the core of the dissociative dynamic. The complicating idea here is developmentally, if children are subjected to that level of suffering, that level of torture, of rape, of enduring sexual trauma repeatedly throughout childhood, they shouldn't have any relational dynamics at all. And yet I find these patients, and McWilliams find these patients endearing almost. They want connection. They don't trust very easily, obviously, but they seem quite motivated to make some kind of connection. Therapeutically, when you begin touching on areas that evoke anxiety in them, one of the main manifestations that I have seen is that they are capable of dissociating instantly. That you can be carrying on a conversation with them and you inadvertently, or maybe you're trying to sort of see where the boundary is, and you touch on something, and in mid-sentence they'll change the subject completely. One of my first patients who did this would be talking about something, and literally in mid-sentence he would shift. Talking about a childhood experience, talking about something he was doing, and then, did you see the Mariners game last night? I mean, it would literally be that kind of a left, and it was as if he had no memory of the previous discussion. And the 3rd or 4th time he did it, I sort of stopped him and said, John, did you notice what just happened right there? I asked you a question and you just shifted in the middle. And he said, oh yeah, when I do that, my friends think I'm crazy. And I said, oh, so you've experienced it before. Can you tell me more about how that happened and kind of what's going on when you do that? And it became very clear that that was the way he defended against the evocation of catastrophically traumatic childhood experiences. It didn't help him. It was necessary as a childhood dynamic. He had no choice. It wasn't what he chose. It was the only way his mind could avoid the unspeakable trauma he had to endure as a baby and very young child. But it certainly led to his being fairly dysfunctional in his young adult life. So if the therapist can lean into that and provide a rock solid frame, A therapist with a dissociative patient must recognize that impinging interpretations, aggressive behaviors, are re-experienced trauma to the patient. I'll use my kitten metaphor again. A dissociative patient with a trauma history is like a kitten who's hiding under the bed. I've asked patients, and students sometimes, how do you get a kitten out from under the bed in a way that's actually good for the kitten? You can't just reach under and grab him. You can't just get the broom and make him come out. You can't bring in the dog. You can't lift the bed up. You got to wait. You got to be trustworthy. You've got to be so calm and such a soothing, peaceful, safe presence that the kitten slowly comes out and develops a sense of trust through experiencing you as safe. That's the therapeutic stance with a dissociative patient. I don't think anything else is ever going to work. As soon as you start pushing, they'll go away, psychically, if not physically. Lastly, I think there is a significant overlap between the dissociative patient and the depressive. Most of the time, the dissociative patient has taken in an experience of their own badness. They must be bad or they wouldn't have been made to suffer so. So I think that dynamic is often substantially overlapping in the worst elements of the depressive. There very rarely seems to be a manic acting out in dissociative dynamics, but clearly there is a profound depressive dynamic there. They very often blame themselves and go down that road. Therapeutically, lastly, one finds with dissociative patients the need for the therapist to be a little more real, to be perhaps carefully and thoughtfully a little bit more self-disclosing. You need to carry on a little bit more of a reality-based conversation. The patient needs to know a little bit more about you. This is controversial in my field, but I think I am comfortable when you're dealing with that much trauma. The boundaries of the classical formulation need to be stretched just a little. The focus has to be, for a dissociative patient, in the here and now of what they're doing. It's important to get a detailed case history a little bit, but it becomes very clear that spending hour after hour talking about the details of their hideously traumatic childhood is often itself re-traumatizing. Get as much as you can, as much as you need to, but recognize that really it's about helping them recognize what's going on in the here and now, and that's the safer focus, it seems to me. All right, I would like just to take a few minutes and summarize the entire course of psychopathology. If you took in McWilliams' little chart, the idea of the structural vertical axis, the neurotic, the borderline, and the psychotic, if you add to that the defensive style within that structure, you have a pretty good picture of someone's mind if you understand the elements of each of these and what would constitute being in one place or another on the chart. But that is a completely different way of thinking about the mind than a checklist of symptoms, disregarding the person's history and dynamics and unconscious experiences. The meaning of those childhood experiences to the patient are why and how these defensive reactions get put in place to begin with. Checklists of observable symptoms will not give any therapist, I think, a meaningful way to treat a human being who is suffering. I think if a therapist can maintain the stance of sort of non-judgmental understanding and deep curiosity, what I call benevolent curiosity about what the person's experiencing, simply staying open to the patient's experience. Most of these patients who have been traumatized, who have been neglected, who have taken so much blame and guilt onto themselves most of the time, to find someone who appears to be non-judgmentally and with some honest benevolence, curious about how their mind is working, can evoke those elements in the patient that are, I think, existentially almost starving for an opportunity to grow and to become stronger. This takes tremendous skill and discipline and training and patience on the part of the therapist. It also takes a great deal of the therapist's own therapy to be able to manage their inner experience of these things themselves first. I hope this has been informative. I hope this is the starting point for all of you to recognize what's going on inside your own minds and to provide help for others who are suffering. Thank you very much.